Good morning. Welcome to Understanding Healthcare Coverage, Part 2, a conversation on Medicaid expansion. It's a pleasure to have you here today with us. My name is Cheryl G. I'm your moderator today. I am a colorectal cancer community partnership member, a volunteer, and I have been for the last 4 years. My co-moderator is Marilyn Wilson, and she will introduce herself as well as our guest speaker.
Good morning, everyone, and welcome to this timely discussion. Thank you, Cheryl, for introducing me again. My name is Marilyn Wilson. I am the program manager over community outreach and engagement programs for the Elimination of Cancer Disparities, better known as PCAD. Again, welcome to part 2 of the timely conversation. As I said before, I have a few announcements before I introduce our speaker for today. Please feel free to launch your questions in the Q&A section that is located at the bottom of your screen. We will make sure your questions are addressed after the speaker's presentation. We will launch a pre-poll of 2 questions on today's topic, just to get an idea on what you already know. The answers to these questions will be anonymous, so no one will know your response. Okay, I just shared some of the results. So during this pre-post, as I said before, just wanted to kind of gauge to see what you already know. There will be a post-poll at the end of the discussion to see what you have learned thus far after hearing Dr. Joynt Maddox's presentation. So allow me to introduce today's speaker. Dr. Joynt Maddox is a practicing cardiologist at Barnes-Jewish Hospital and an assistant professor at Washington University School of Medicine and Washington University's Brown School of Social Work. She is the Associate Program Director for Diversity, Equity, and Inclusion for the Washington University Cardiology Fellowship Program. She is co-director of the Center for Health, Economics, and Policy at Washington University Institute for Public Health, as well as a health policy advisor for BJC Healthcare, a 15-hospital system in Missouri and Illinois. She served from 2014 to 2016 as senior advisor in the Office of Health Policy in the United States Department of Health and Human Services. Without further ado, allow me to introduce Dr. Joynt Maddox.
Good morning, everyone. I am just thrilled to be here with you all today and very appreciative of the opportunity to get to talk with this group about an obviously very timely issue, Medicaid expansion. Let me share my screen here. Get this up and going. Here we go. Okay, so these are my disclosures. As was noted, I previously worked for the government, for the federal government, and have some grant funding related to payment models in Medicare, which is unrelated to what I'm doing today, and serve on the Centene Health Policy Advisory Committee. Okay. Based on the results of the pre-poll, I know that many of you know what Medicaid is and who it covers and all that sort of thing, but I'm going to go through anyways as sort of a little bit of level setting to understand where expansion really comes in, both nationally and then more focused on Missouri for sort of the latter half of the presentation. So as many of you know, Medicaid is a state-administered program that provides health insurance coverage to people living in poverty. And Medicaid goes back quite a ways. It was created in 1965 along with Medicare. And while Medicare is run by the federal government and focuses on people who are age 65 or older or have other special qualifying conditions, Medicaid is really run by the states. Even though it's run by the states, it's actually funded a little bit more by the federal government than the state. So it's about 60-40 overall, federal, state. Now, match rates, which are the amount of the bill that the feds pick up versus state does vary somewhat by state, and that is based on state income, average per person or per capita income in the state. So for Missouri, the federal government pays about 65% of our Medicare bill, and the state pays about 35%. You can see in that map on the right of your screen that the federal matching rate does vary quite a bit across the country. So the states with the highest per capita incomes, you can see much of the Northeast, New York, Massachusetts, New Hampshire, as well as California, Alaska, Washington, for example, split it 50-50 with the federal government. Then there are 10 states where the federal government picks up about 3/4 of the bill. And you can see that some of the states with the lowest per capita income. So Arizona and New Mexico, Arkansas, Missouri, Alabama, South Carolina, Kentucky, West Virginia, and DC. Missouri, as I said, is 65-35. So we're sort of in the middle there in that sort of darker blue color, along with Iowa, Oklahoma, Texas, Louisiana, and sort of some of our other neighbors. Now, in addition to that match rate varying by state, benefits and eligibility also vary by state. So all states cover pregnant women and most children up to 200 to 300% of federal poverty, which is $12,000 per person, as well as people with disabilities. And that's part of the federal mandate. So to get any Medicaid money, to essentially have a Medicaid program, you need to provide coverage for certain groups. But states vary quite a bit in coverage for other populations. And we'll go through all that, sort of exactly what it looks like in Missouri later, but I'm going to go through more generally now what that looks like. So if you think about all the groups that can be in Medicaid, thinking about who that is and where the spending goes is kind of interesting. And at least for me, it's sort of counterintuitive when I learned about it initially. So Medicaid covers 76 million beneficiaries, half of all births, and 60% of nursing home care. So Medicare, which is the program that most people over 65 in which they are enrolled, only covers nursing home care immediately following a hospitalization. So a couple weeks of rehabilitation, basically. Any chronic long-term care in nursing facilities is covered by Medicaid or by private insurance, but it's not covered by Medicare. And that in and of itself is an enormous amount of spending within the Medicaid program. So you can see in those bar graphs on the right that although children who are in green and adults who are non-disabled are in blue, these are national numbers, they make up almost 80% of enrollees. So the leftmost bar, let's see, my cursor on the right screen here, has children and adults making up almost 80% of enrollees. But if you look on the bar on the right, those two groups are less than 40% of total spending. So per person, those groups are pretty cheap, which is good. Most kids are pretty healthy and don't have very much spending when it comes to medical care. And most sort of, working age adults similarly don't have super expensive medical stuff. So they're the majority of the enrollees, but not the majority of the spending. And that will be very relevant when we think about who's going to join the program in Missouri going forward. Now, individuals with disabilities or those over the age of 65 are expensive relative to their prevalence, right? So that's where we see a high concentration of things like chronic nursing home care or other sort of major care needs, particularly in the group with disabilities, as you can imagine, sort of by definition, have pretty significant health needs that can be quite expensive. So those two groups together make up over 60% of spending, despite being only about 20% of the people in the program. So Medicaid expansion nationally was created under the Affordable Care Act. Now, some states expanded early. So some states had sort of, even prior to Medicaid expansion, like Massachusetts, for example, started expanding their own program, basically seeing it as a good way to improve the health of their state. And then some expanded after the Affordable Care Act was announced, but before the 2014 sort of go live for that expansion under certain waivers. But the biggest chunk of states expanded Medicaid in 2014. Now, since then, some have expanded. For example, Missouri and Oklahoma are the two most recent to have voted this into being, though neither have actually expanded yet. We will spend some time talking about that later too. One of the sort of carrots, I guess, to encourage states to expand was offering a high match rate. So remember, I told you that many states have a 50% match rate. Missouri's at 65-35. The expansion population was initially offered a 100% match rate, and then it dropped to 90%, which is where it is now, for states to expand Medicaid to everyone, regardless of whether or not someone is pregnant or has children or whatever, no other sort of requirements, under 138% of federal poverty. Now that was subsequently declared voluntary under the National Federation of Independent Business versus Sebelius, which is a lawsuit that was brought against the Affordable Care Act. And this chunk of it, so Medicaid expansion, was declared voluntary, meaning that states had the option to expand, but were not required to expand, which is why we have ended up where we are, which is a patchwork of approaches to Medicaid across the country. So we know nationally that despite not all states expanding, the Affordable Care Act and largely the Medicaid expansion contained within it was very successful in improving insurance coverage. So you can see in this graph that between 2008 and 2013, roughly, you can go back even farther, but it makes the graph look a little silly. We had an uninsured rate that was around 15%. So about 15% of the population, with huge variation by state, which I'll show you, was uninsured. And obviously we know that uninsurance comes with a whole host of issues, which we'll go into, but that had been sort of the state of affairs across the country for quite some time. And then between 2013 and 2016, so 2014 was sort of an in-between year as states expanded and people started enrolling, we sort of settled out at more like 8.5%, 9% uninsured. So about, roughly a drop from 15% to 8 to 9%, pretty big chunk taken out of the uninsured rate. It has trended back up a bit between 16 and 19 based on some changes under the previous administration around making the individual mandate no longer enforceable. And of course, 2020, I think, is completely unclear as to what that will look like with COVID. We know that lots of people lost their jobs and with it their insurance, although the people who were most likely to lose their jobs were ones who may not have had insurance to begin with. We also know that some people got COBRA, some people got, other ways of sort of extending coverage, and then some got back on coverage as the hiring has picked back up at the end of the year. So it's really difficult to know what 2020 is going to look like. And we don't have final numbers yet on exactly what insurance has done. So I would say the end of this graph is TBD. But we can at least look back and say that historically, prior to COVID, we know that about 2/3 of the gain in the drop in uninsurance, or the gain in insurance, depending on how you want to look at it, was because of Medicaid expansion. So as of now, I guess it's April, but as of close enough to now, this is what Medicaid expansion looks like across the country. And this doesn't show the ones who did early or later or whatever. It just sort of says as of current, where are we on Medicaid expansion? So you can see that essentially the entire Northeast and upper Midwest has expanded. Missouri and Oklahoma, as I mentioned, voted Medicaid expansion in, though it has not actually happened yet. So that's why they're sort of shaded blue, because theoretically during this year they will be expanding, but it hasn't gone live. The orange states are all the ones that have not yet adopted. And, there's a pretty obvious geographic distribution to these decisions. You can see that essentially the Southeast has not expanded Medicaid and every place else has. I guess Texas isn't really Southeast, but the exception of Wyoming and South Dakota. Kansas has had a lot of ongoing discussions. The governor is in favor of expansion, the legislature is not. That may be the next place where we see sort of a popular vote take place, given the very clearly divided interest in Medicaid expansion across the state. They're certainly also watching Missouri and Oklahoma to see what that looks like. Wisconsin, though it looks like a non-expansion state, actually has a pretty generous existing program, which I'll show you. So they're a little bit atypical. They're sort of quasi-expanded anyhow, but I think they are also weighing expansion, given some new sweetening of the pot under this current administration, which we will talk about later. So the result of these different decisions across the country is enormous variability in whether or not people can access Medicaid who do not fall into those statutory groups, meaning pregnant women, children, people with disabilities, or people over 65 living in poverty. So essentially working age adults with or without children. So working age adults with dependent children, which is this graph on the left, in all expansion states. So I'm sort of unfortunate I made it orange because it's all the blue states from the prior graph, but those are at the bottom. So 138% of poverty means that you're eligible for Medicaid in every state that has thus far expanded. And you can see across the rest of the graph here, all of the eligibility cutoffs in other states that have not expanded for what income level disqualifies you from receiving Medicaid. And you can see Missouri is in the tan bar up here at 22% of federal poverty level. So one of the lowest cutoffs in the country, only behind Alabama and Texas, in terms of who can get Medicaid. So if you make anything more than 22% of federal poverty, which as I mentioned is whatever that is, $10,000, $12,000, you do not qualify for Medicaid. So essentially any work disqualifies you from receiving Medicaid. And obviously given the price of purchasing insurance, if you make enough to not qualify for Medicaid, there's still no way you make enough to actually buy insurance. So adults with dependent children, many of whom are working, are really stuck in this state because there's no option to get insurance. It's not realistic to buy private insurance. It would be literally more than your income in many cases, and you just don't qualify for Medicaid. Adults without dependent children are even in a trickier spot. And again, many of these folks are working, but if you make any money at all, you do not qualify for Medicaid. And obviously, if you make low amounts of money, you also can't purchase health insurance. So with the exception of Wisconsin, which is in the blue bar at the bottom here, as I mentioned, their program is different to start. All of the non-expansion states, if you are an adult without dependent children and making, well, you just don't qualify, regardless of whether you make any money. You can make zero and not qualify. You just can't get access to Medicaid. Consequently, insurance coverage is very uneven across states. And so you can see that Texas has the current highest uninsurance rate in the country at a little over 18%. Missouri is sort of low middle, I guess, with around 10% uninsured, all the way down to Massachusetts in the purple bar down here, which is at about 3%. So, 6x difference between the highest and lowest in terms of uninsurance rates across the states. This is as of 2019, but it hasn't changed meaningfully, COVID aside. So why does this matter? So now we've sort of gone through like, what is Medicaid? Who has it? Who doesn't? How does that vary across states? And now the question is why is that important, right? What does that translate into from a health standpoint? Now, I will say that because we are 7 years out from expansion in many states, we have quite a bit of data. And there's hundreds and hundreds of papers on all this. So I've sort of summarized, and I'll go through a few key data points to sort of try to give a feel for what the positive effects of Medicaid are. I'm really not cherry picking studies here. I'll give you the overview and then show you some exemplar studies, but I'll point out where there is and isn't good evidence. So the first thing we'll talk about is that there is unequivocal evidence that Medicaid is associated with better financial protection for individuals, hospitals, and states. So obviously individuals being protected from bankruptcy is a good thing. We also know that hospitals in expansion states have had fewer closures and better financial margins, which has big implications for rural areas, particularly rural areas that are disproportionately Black or Hispanic. And then states, which we'll also talk about. There is strong evidence for greater access to primary care, more ambulatory care visits, more use of prescription medications, better adherence to prescription medications, and more access to preventive services, which has huge implications for long-term health in cardiovascular disease and cancer in particular, though also in pretty much anything else you can imagine. There's moderate evidence for better self-reported health. So do people, report that they are better off after having coverage? The evidence for mental health is quite good. Actually, people just feel better knowing that they're covered, which is, understandable. The physical health looks like it takes a little time to accrue. There's mixed evidence for utilization. I'll show you those data also, but you can imagine if someone hasn't had coverage and then gains coverage, their use could actually go up, right? Which it should. If you've been putting off, getting that chest pain taken care of, and then you have coverage and can do it without bankrupting your family, you are actually more likely to use healthcare in the short run. There is growing evidence for lower mortality, infant mortality, cardiovascular mortality, and likely cancer mortality, depending on which cancers you look at, because obviously the timeline is different based on different types of cancer. But really mounting evidence that this is associated with actual reductions in long-term mortality rates in states that have expanded versus those that have not. And I think super importantly, the impacts are clearly the largest for racial and ethnic people who are minoritized and in rural areas. These are the groups that have had the lowest level of insurance coverage to start. Therefore, the groups that are gaining the most under Medicaid and whose health is improving the most. And I can't emphasize that enough, that this is an area where we see Medicaid expansion actually help to address rather than widen health inequities, which is not true for many things that we do in healthcare. So going through some of the details here. So we know that expansion is associated with lower out-of-pocket spending for low-income adults. So here you see the purple bar is out-of-pocket plus premium spending, so about $2,000-ish a year. The purple is non-expansion states and the yellow is expansion states. And you can see that after expansion, the out-of-pocket spending in those states really starts to drop off, dropping from close to $2,000 down between, closer to $750 or whatever that is, which is very meaningful in terms of keeping money in people's pockets for housing and food and those sorts of things. So pretty clear evidence that out-of-pocket spending goes significantly down. We also know there are economic benefits beyond health alone. So as you can imagine, debt is debt, and people who are trying to avoid taking on medical debt are likely faced with other challenges as well. And so this is a fascinating study looking at the effect of expansion on evictions and eviction court initiations. And you can see that in Medicaid expansion states in the red line that the rate, the evictions per 1,000 renter-occupied households actually dropped off significantly in expansion states, suggesting that providing healthcare to people removed the financial strain and allowed people to stay in their homes, be that because of avoidance of bankruptcy or just lower out-of-pocket costs. It's obviously a mix, but pretty good evidence that this, this has economic effects beyond just healthcare. As I mentioned, we also know that expansion has been associated with fewer hospital closures. Now, this is a bit of a funny looking graph, but the orange part of the graph is before the ACA. The blue part of the graph is after the ACA, moving from sort of announcement of the ACA in that first bucket into what is labeled as expansion policy known, but basically we know which states are planning to expand, and then in the last chunk, Medicaid expansion implemented. And you can see that hospital closure, so per 100 hospitals per year, have been rising since 2010, but almost exclusively in non-expansion states. So non-expansion states sort of saw this big bump in hospital closures that has sustained between 2013 and 2016, and actually this has continued, whereas expansion states have seen that closure drop off quite a bit. As you can imagine, these are not all, but many are small rural hospitals that have a very difficult time keeping their doors open with low volumes and a lot of people who are uninsured. And so bringing insurance to those areas, we'll see this pattern in Missouri in a bit, that rural areas do disproportionately benefit actually from expansion, has allowed those hospitals to stay open, which is obviously crucial in terms of access to care for all sorts of conditions. We also know, and we'll come back to this too, that the increase in Medicaid spending has been entirely federal funds. So as I mentioned, the expansion dollars are mostly federal. States kick in a little bit, now we're at 10%, but there are offsets, meaning that because of that match rate, you can actually shift some people who were in the old match rate into the new match rate and offset some of the costs. Also, other spending in state budgets goes down with Medicaid expansion. So we can talk about the details, but essentially there's a lot of offsets in the state budget where Medicaid helps things. And so you can see in the states that have expanded versus not, looking between 2010 and 2018, spending from federal funds at the state level, meaning the per state spending, which is obviously different in California versus Vermont, but as a percent of their baseline spending, went up by about 25% per year. So states are pulling in a quarter more federal funding than they were before expansion. Spending from state funds is basically flat. There was a non-statistically significant bump in 2015, which is probably mostly implementation costs, so states getting new systems up and running, but then a quick return to essentially exactly the same baseline spending. So pulling in a bunch of new federal money, but not actually impacting state budgets, which is very relevant to the debate currently going on in Missouri. So what does it do for patients? So we talked about the financial implications. What about access to care? So we know that in expansion states, the share of adults that avoid medical care due to cost dropped significantly compared to non-expansion states. Now it went down in non-expansion states too, because you'll remember that about 2/3 of the improvement in coverage is from Medicaid, about 1/3 is from these new exchanges, the quote unquote Obamacare that was created. And that was an expansion and non-expansion states. But you can see that in groups from 2013 to 2018, the left-hand side here, expansion compared to non-expansion, a really significant drop in the proportion of adults avoiding medical care due to cost. And that was both disproportionately suffered by individuals of Hispanic or Latinx or Black or African American background prior to the ACA, but also had the biggest drops in those groups post. So we still see significant inequities in who avoids medical care due to cost, but the improvement has been disproportionately in those groups, particularly compared to the non-expansion states where the improvement has been less. So you can see that all of these groups have come down over time in terms of having not avoiding care due to cost concerns. Now, we also know that access to very specific services that we would think of as sort of healthcare quality and very important for cancer outcomes improved in Medicaid expansion states, and in this case within Oregon. So Oregon was a very interesting Medicaid expansion. So Oregon expanded, but they didn't have enough money. This was before national expansion. So Oregon was one of these early states. They essentially had a chunk of money and they realized they could expand Medicaid, but not to everyone. So instead of setting a cutoff that was, instead of saying, okay, we're going to go up to 100% of federal poverty and we can cover everyone, they went up to 138, but said we're going to have a lottery. So people could enter into this lottery to get Medicaid coverage, and which is kind of wild that actually happened in a state, but it did. And so then they have a comparison between people that were eligible but didn't sort of win the lottery that year versus adults that were able to access Medicaid. So you can see that among those who did receive Medicaid, compared to those who were eligible but didn't, there's much higher rates of getting your cholesterol checked, double receiving appropriate mammography for breast cancer screening for women 50 and older, prostate cancer screening, recommendations have changed since then, but prostate cancer screening, having a usual place of care, so having primary care, receiving all needed care in the past year without cost barriers, and an increase in folks who were prescribed opioid treatment medication, just in terms of thinking about other specific treatments to which people gained access. Now, as I mentioned, there has been sort of mixed evidence on the association between Medicaid expansion and healthcare utilization, in part because when people gain coverage, they may utilize more healthcare. And so you can see here that in Arkansas and Kentucky, when they expanded, they actually saw a drop in the rate of emergency department use. The Oregon experiment that I just showed you had an increase in the rate of emergency department use. And Tennessee, which actually expanded and then contracted, saw a huge drop in emergency department use when they took Medicaid away from people. So on balance, expansion probably increases emergency department use in the short term and decreases it in the long term. But this I think, remains a bit of an open question about what would happen to emergency department use and what might happen in Missouri to emergency department use patterns. What we are seeing more of as we have more time since expansion is the association between expansion and lower mortality, including infant mortality, cardiovascular mortality, and cancer mortality. And so you can see some of the studies here looking at infant mortality on the top, cardiovascular mortality in the bottom left, and then cancer mortality here, suggesting that the expansion states have better survival after cancer diagnosis, looking over time. We will have better and better information on this as time passes, because obviously things like cancer detection, screening, detection, treatment, there are so many steps in the cascade, and in many cases is a chronic disease that it takes time to understand these effects. But the longer we look, the more we're seeing pretty clear evidence of benefit for these longer term conditions. And as I mentioned, these impacts that we're seeing are across the board, largest for individuals in racial and ethnic minoritized groups and in rural areas. So if you look on the left, you can see the proportion of new coverage in Medicaid and the drop in uninsured rates were highest among Black and Hispanic individuals. So gained the most Medicaid and had the biggest drop in lacking insurance under the ACA. And then on the right side of the panel, you can see the effect of Medicaid expansion on patient volumes at community health centers, showing that in urban areas, there was essentially no change in this column for folks coming in for various stuff. And in many cases in urban areas where there may be other care sites, we suspect that people who gain coverage sort of fan out more across different places where you could get care. In rural areas, there were really marked improvements, assuming this is all good, of people coming in to get treatment. In rural areas, there's many fewer clinics to which one could go. So these increases reflect basically people gaining coverage and coming in to get things like their mammogram, their flu shot, treatments for diabetes, heart disease, depression, and anxiety. So let's talk about Missouri. So currently in Missouri, children are covered up to 305% of FPL, pregnant women up to 201%, parents at 21%, as I showed you, which is that third to lowest nationally. Childless adults have no way to get coverage, and seniors and people with disabilities are covered up to 87% of federal poverty. And you can see the numbers up here, $21,000 for a family of three, $12,000 for an individual. So pretty low if you think about, 20% of this disqualifying you from getting Medicaid. So Missouri Medicaid expansion passed by popular vote, 53.3% to 46.7% in 2020. It wasn't close. I mean, that's a huge margin. though certainly it was quite regionally variable, and I'll show you a map of that in a bit. And the plan is for that to be implemented in July of 2021. Now the projected savings, so this is some work that our center did prior to expansion, and you can see we projected in the orange line savings that would accrue to the state compared to had we not expanded, largely around that better federal match rate. So as I mentioned, plenty of people would qualify for Medicaid who are currently under the disability pathway or other sort of groups that would bump into that better federal match rate. So we get a lot more federal money and therefore can spread out the state money across more people. And this analysis doesn't even take the other positive effects into account, which we'll touch on in a minute. And then of course, the American Rescue Plan, the more recent bill from this administration, has huge additional incentives to get Medicaid expanded. So we're talking about really big money potentially coming into Missouri as a result of expansion. So as I mentioned, voters approved adding expansion to the state constitution, which is not how it was done in states that expanded under the typical means, but if you're going through this sort of popular vote pathway, this is sort of how it ends up getting done. And this amendment to the Constitution requires that Missouri submit what's called a state plan amendment necessary to implement expansion to Medicare. CMS is Medicare, Medicaid, so I should say Medicare, Medicaid, but to Medicaid no later than March 1st, 2021, and that happened. And then the coverage is to begin July 1st, 2021. So that's what the amendment states, that we will submit our plans and then, should that be approved, move forward with expansion in July. There is in the language the criteria that it cannot impose any additional burdens or restrictions on eligibility or enrollment. So that's meant to sort of say, and it cannot include things like work requirements or other mechanisms attempted to put into place to limit the population. But essentially, if you are eligible, you will be able to enroll. So we've estimated that under the expansion, there would be about 250,000 new covered lives. The state has estimated 275,000, we got 250. I think you can safely assume it's somewhere in that range. About 2/3 of the people who are newly enrolled, we suspect will come from people who were previously uninsured. About, a third, a little less than a third will come from people who are in private plans, mostly people who made just enough to buy, a cheap plan on the exchanges, but not enough to sort of stay in that group if a more cost-effective alternative were available. And then a chunk of adults who are on employer plans, either because employers will stop providing the plans or because they are bouncing on and off employer plans anyhow. So that's our best guess for sort of who will enroll. Now, as I said earlier, in general, we suspect that some of these folks will be pretty inexpensive because they'd fall into that sort of working adult without disability or long-term care needs bucket. Some of the people in the uninsured group will have pretty significant care needs, undiagnosed, or at least I should say undiagnosed, but unformally diagnosed disabilities or care needs that had not sort of made it quite through the process, but will bump in under this group here. If we look at the geographic distribution of where we anticipate that that people will enroll, it's actually sort of opposite how people voted on this, interestingly. So 3.6% of the population in the St. Louis region, we estimate, will be newly eligible, compared with a high of 8.5% in the South Central area. That's quite similar to the Southwest area you can see in the map here. The darker colors indicating the places where the population prevalence of eligible people to enroll is highest. So, 8% is a big number and much, much higher than 3.6%, obviously. So we suspect that there will be a lot of eligibility coming from these parts of the state. We estimate that 41% of new enrollees will be in rural areas compared to 32% of the population of Missouri being in a rural area. So the fiscal impact, and this is where a lot of the arguments have sort of been in the news and in the legislature recently. So as I mentioned, the administration has estimated that expansion will cover 275,000 adults and that about 150,000 would enroll in the first month. And that's sort of how this typically goes in other states. You have a bunch of people who know they're eligible, who are ready to enroll, who will do so quite quickly, and then a bunch who won't enroll until they have a health need or some other reason to sort of be spurred to do so over the rest of the year. So you see maybe half of your bump in the first few months of expansion, and then the rest over the remaining course of the year. The total costs of expanding coverage are estimated to be almost $1.6 billion. But given the 90-10 federal state match, even before considering a few additional things, which I'll talk about in a moment, the state share would be about $130 million. So spend $130 million to get $1.6 billion, basically. Some of which we're getting now, but obviously an increase based on all of that additional coverage and that additional money. Now that estimate doesn't really include very many savings from other programs. It includes some of the savings from the enhanced match, like I mentioned, people moving over from one track to the other and being in a higher match group. That doesn't take into account anything in the savings and mental health costs, corrections costs, other things that we know are impacted by Medicaid expansion and eviction costs for that matter, I suppose, that we suspect will have positive effects on the state. Other things that were not accounted for, even in this current argument being made around the $130 million for $1.6 billion, there's two bumps that have come in more recently that make this an even more attractive financial deal. So there's a temporary increased federal match due to COVID. So it's a percent bump, and it would cover another $376 million in fiscal year 2022. And then the American Rescue Plan, as I mentioned, has an increased funding for expansion states that we estimate would bring in another $1.7 billion over 2 years. Other savings, again, I mentioned this briefly, the groups that can choose the expansion path versus a prior path like disability, for example. Someone who has disability but can quickly get covered based on income may not go down the path of needing to get all of that confirmed in order to get Medicaid if you can just get it because you have low income. And that group gets a much higher match rate. So some number of people will shift from the disability track to the non-disabled track, which will help the state financially. Wouldn't make any difference to the individual necessarily. We estimated close to $170 million in savings from that track. The governor's budget estimates $20 million in savings, maybe it's somewhere in between. The other thing that's not counted here is the increase in revenues. So as I said, other states have found big increases in state income and sales taxes because it creates not only coverage, but consequently business, right? And sort of hate to say it that way, but if people are covered and they're seeking care, that then gets paid for, and it's paid to the hospitals, it's paid to the health centers, it's paid to the doctor's offices, it's paid to their, x-ray facility. And so that then generates income and sales tax that goes back to the state. And that again has been estimated at up to $100 million per year. So lots of reasons to think that this would be a very, very good financial deal for the state on top of all of what we know about what it could potentially do for the health of the state, which I would argue has, I shouldn't say unmeasurable, someone can measure, but arguably has massive long-term implications for the financial health of our state, as well as moral implications for how we treat our fellow Missourians, in my opinion. So what is this you've heard in the news with voting it down? Well, this is sort of where we're stuck now. So the House Budget Committee voted on party lines not to pass a bill allowing spending. So in order to give this coverage to the expansion population, you have to spend your 10%, which is, like, as I said, $130 million. The governor has said that that would not require any new taxes. It doesn't require any new revenue. We have enough to cover it. So there's no new money needed, but it does have to be appropriated. So it has to be put into the budget so that it chunks into that sort of spending pathway. And so the Budget Committee voted not to do that. That said, the governor has said that he does plan to continue to move forward with expansion. Presumably he has seen those numbers and understands, despite the political sort of posturing, what that could potentially mean for the state. And the state, so the agencies that have to put together all of these plans, has continued with a good faith effort to do so. So they turned in the application, the programs, plans, regulations have been working on how to improve the Medicaid program while expanding it. So thinking about more use of health homes and attention to social determinants and all sorts of things that the program would very much like to do. And with this additional funding could potentially make some real positive changes to the program. Now, what we're seeing is that this sort of political debate is happening, as you can imagine, along party lines. And if you look in this graph on the right, you can see the range of votes for and against Medicaid expansion. Now, ironically, the darkest red counties here are the same ones where the highest number of people would be eligible for Medicaid. But these are the places that voted the most vehemently against, the sort of South Central and Southwest, a little bit of the Southeast, and the sort of Northeast corner. Very, very strong support in St. Louis City, County, St. Charles, Jefferson, Jackson, Clay, the stuff over by Kansas City. And, you know, again, ironically, the places where the fewest new people will be eligible are in these places that voted for it overwhelmingly. There's a lot of misinformation about Medicaid floating around right now. And so this has become a very partisan, very contentious debate where legislators from different counties and different districts are feeling like they need to sort of answer to their constituents or sort of tell the party story. And I think if you look at the number of states and breadth of states politically that have expanded nationally and what it's done for their health and economy, like this need not be a political debate. But that's where we're stuck right now at this moment in time. Realistically, if this is written into the Constitution and the voters approved it, it needs to happen, and lawsuits could be brought if the legislature doesn't move forward. But it could sort of slow things down and make it much more difficult to move forward. So that is that's where we are now. And I wish I had a more certain answer for you about how this would all go, but I don't, because of the ways that the political system works. So in summary, Medicaid is associated with better health and better health outcomes and likely lower mortality. It is also associated with financial benefit to states and hospitals, in addition to its obvious immediate financial benefit for individuals. Missouri Medicaid expansion may be rocky. It will likely happen. There are certainly no guarantees because the legislature can do all sorts of things, but in theory, this was written into the Constitution and should move forward. And as it does, it will be very important to track its impacts on health for things like cardiovascular disease and cancer in particular, where we know that the long-term effects may be more difficult to find, but extraordinarily important for the long-term health of our state, as well as its financial impacts. So I will stop there and glad to take questions. I'll stop sharing so I can see the chat also.
Okay, let me see. Am I back up?
All right, should I go ahead and work down some of the questions in the?
Yes, I don't see, this is Cheryl. I don't see myself back up on the screen.
I don't see your picture either. I see your name.
Oh, I don't see my name.
I can hear you.
Okay, give me just 1 second here. Okay, here I am.
There you are.
Okay, well, first of all, thank you, Dr. Joynt Maddox, for the presentation that you provided to us. I do have a couple of questions. And one is, under the Medicaid expansion, what are the coverage requirements for screening such as breast cancer, colorectal, and prostate cancer?
So under expansion, states are required to provide essential benefits. And so cancer screening falls under that, and they're required to provide them free of cost. So those should be covered, and they should be covered without significant copays as preventive care. There have been a few attempted tweaks by the legislature around coverage, but to my knowledge, there has been no attempt to change those. So those should be essential health benefits and covered under Medicaid.
Okay. The next question is, will the slides be available after the presentation?
Sure.
Okay. And let's see, there's another question. It says, pardon my lack of understanding, but why would someone not want to expand if it provides more coverage and it will increase savings? Seems like a win-win.
Yeah, I'm with you on that one. And it's my lack of understanding too of sort of the strength of the political moment that we're in. That something that seems like so obviously a good idea for the state, both fiscally and from a health standpoint, could be opposed on these sort of political grounds. The argument that's being made is fiscal conservatism, that basically it costs too much money to do this. We can't afford it as a state. And so therefore we need to not spend that money. I don't actually quite buy that argument, because the same people that are arguing that are proposing spending in other areas. And the governor has said that it would not require any additional state money, despite being a very low tax state. So I think it's political, and it is the moment that we are in, and it is hopefully a moment that we will exit over the next few years, because it really, I think, hurts people, all of us, right? It hurts people on both sides of the aisle, people in all counties of the state, to not make policy decisions that are good for everyone. So I don't have the secret answer to that one.
Okay. I am not sure what's going on with my camera.
We can see you.
Okay.
Mhm.
So there was another question. I'm trying to get back in the Q&A. But what are the costs if Medicaid isn't expanded?
If Medicaid isn't expanded, we essentially stay in the status quo. So we continue to pay for our current Medicaid program, but we don't get all that additional federal money. I think based on what we've seen happen so far since expansion, we can anticipate that therefore we would continue to see widening gaps in health inequities, both by race, ethnicity, and by urban-rural status. I think we would continue to see hospital closures. We know that many of our rural hospitals are really struggling right now, and some urban ones as well. So I think if we don't expand, we could anticipate seeing a continued decline. We know our state health rankings have also fallen off quite a bit over the last decade, and it's because we have stagnated or worsened while other states have really improved health through public health measures, Medicaid expansion, things like that. So I would anticipate we would continue to see our state health relative to groups that have really invested in the health of the state continue to decline. It's not, I don't know what the dollar cost would be, but it's not good.
Okay. And I'm not sure if you actually answered this question, but will there be specific requirements for people who are already eligible for Missouri Medicaid to work?
No. So the way that the amendment is written, we cannot put work requirements in or other requirements that would limit eligibility or enrollment. The current administration has also been reasonably aggressive about going back through current waivers and trying to undo work requirements, which, in my opinion, are unethical, but also have been shown just to be ineffective and also quite administratively burdensome without getting you much bang for your buck, because most people who can work are working and want to work, and people who can't don't. So the use of work requirements in other states has essentially just created a lot of additional administrative burden without actually doing anything meaningful for health or coverage. So this administration has been going through and essentially negating those in other states' waivers. So that would not be a requirement here.
Okay.
Okay, Dr. Maddox, just wanted to know, I know questions are really coming in right now, and I'm not sure that we'll be able to get to all of them because we're at time. Would you be open to answer some of these questions via email and we can get back to our participants?
Yep, absolutely. And this is this is an evolving story. So I'm sure many of these things hopefully will be clearer over the next weeks and months. And I hope that, come July, we're all starting to see this successfully moving forward. So everyone stay tuned, and you all know where to find me.
Absolutely. It looks like everyone have posted their answers for our post-poll test here. And it looks as though there has been some difference in the percentage of the answers. So that means people have learned a lot from your presentation. So that's good to see. And I just want to thank everyone again for participating in this discussion. I'm quite sure you will hear more stuff on the news, as Dr. Maddox mentioned, that you're going to hear all types of controversies and things of that nature. But you were able to hear some of the facts, or most of the facts here, and it will be ongoing in the future as this rolls out. So thank you again for attending. And as Kelly mentioned in our chat, if you have any more questions, she did provide her email address in the chat, so you can forward those questions to her and we will get them forward to Dr. Maddox. If there's nothing else, everyone have a great rest of your day.
Thank you so much. Thanks again for having me.
Thank you.